Hi, my name is Amy Swartz, and I'm a CRNA here at Abbott Northwestern Hospital. I volunteered to do a presentation on our histotripsy cases. I'm going to share my screen in order to go through the PowerPoint presentation I created. Okay, I titled this Introducing Histotripsy, Advancing Non-Invasive Therapy here at Abbott Northwestern Hospital. So, what are the clinical applications? Histotripsy can be used for tumors of the solid organs. Those are the liver, pancreas, kidney, prostate, breast, and brain. However, it cannot be used for non-solid organs such as the liver or intestines. Currently, here at Abbott, we are utilizing histotripsy for liver cancer. Its versatility makes it promising for multiple conditions like vascular treatment, blood clots, and preserving organs. So, what is histotripsy? Histotripsy is a non-invasive therapeutic ultrasound technique. It uses focused sound waves to mechanically break up the cancer without utilizing heat or radiation. Thereby, it reduces the harm to surrounding healthy tissue. Histotripsy works by creating cavitational bubbles in the targeted tissue. These bubbles expand and collapse quickly, thereby leaving the tissue fragmented. And cancer cells are dumb enough that they cannot put themselves back together. It is guided by real-time imaging for precision. So, what are the advantages over the other techniques? Let's compare them. So, typically, cancer is removed with surgery, which is invasive and has a prolonged recovery time. Or thermal ablation is when heat is introduced, but it can cause collateral damage to the surrounding tissue. Now, when we compare histotripsy to lithotripsy, histotripsy is continuous sound waves, and lithotripsy is shock waves to break up stones. Unlike surgery and thermal ablation, histotripsy is incision-free, reduced recovery time, and has lower complication risks. Again, it preserves the surrounding tissue, which is very critical for patient safety. What are some of the clinical outcomes? Looking at the Hope for liver trial, 90% of tumor control was achieved at 12 months with strong survival rates and favorable patient safety profile. So, what does this 1 year survival rate mean? Well, in the primary cancer patient, meaning it only is in the liver, there was a 73% survival rate. Now, if they have metastatic liver cancer, there's a 48% survival rate. These actually show the effectiveness of histotripsy. So, looking back at some research, safety, and regulatory status, the FDA approved histotripsy for liver tumors in 2023. Obviously, I said before that research is expanding to other organs. And there are some studies that look at the augmentation of utilizing immunotherapy and boosting the immune system. Histotripsy showed minimal adverse effects and preserved adjacent blood vessels and bile ducts. And again, long-term data is still being collected. All of these risks are minimalized by the imaging and real-time monitoring during the procedure. So, what are the challenges and limitations of histotripsy? The equipment cost is extremely high, and there needs to be specialized training of the physicians utilizing the equipment. There are only 50 lithotripsy locations in the United States, which makes it unavailable to many patients who have cancer. Lastly, Again, long-term data is needed. We only have roughly 1 year of the liver results out. So looking ahead, histotripsy may be integrated with artificial intelligence for more precision. It is looking at expanding its application in oncology. There is potential for robotic integration and making it more portable. And finally, it has the potential to transform standards of care. Care 11 back in August did a segment on histotripsy, and I'm going to show you that clip right now.
Industrial Park in Plymouth is home to one of
the news. I'm Janice Shortle. So a med tech company, a startup that you've probably never heard of, just got a massive infusion of cash from one of the richest people in the world, Jeff Bezos. The Amazon founder is part of a group of people that spent more than $2 billion on a majority stake in Histosonics. Why are we talking about this? Because it's based in Plymouth. So Kent went today to check it out.
a nondescript industrial park in Plymouth is home to one of the most buzzed about medical device startups in recent years.
That is the natural sound of histotripsy.
If that therapy doesn't sound familiar,
Histotripsy.
Mike Blue, CEO of Histosonics, says that could be changing soon. The medtech company has spent more than 15 years perfecting this robot,
Very subtle motions.
which produces ultra-precise ultrasound waves to target tumors in a new way.
Millions of nanometer-sized bubbles that are rapidly expanding and collapsing, which ultimately is what is destroying the tissue at a subcellular level.
We sped up this demonstration to show how quickly those bubbles destroyed this piece of sample tissue.
Danica is removing the phantom with the treatment area, and you're just going to slice right down the middle.
And less than 2 minutes later,
That was a solid piece of fibrotic liver tissue. Now it's pate.
Wow, that's wild.
And this is for our physicians, the aha moment. They would tell you that there's no cellular debris. There's nothing really recognizable. It's dead at a subcellular level. There's nothing like this that exists today.
but it's not just physicians who've taken notice.
So this is our proprietary membrane that we've
In
created. 2023,
the FDA approved the machine for treatment of liver tumors.
So this is how we set up over the patient.
And the non-invasive, non-toxic approach quickly gained traction.
Well over 2,000 procedures.
So far, about 50 U.S. hospitals have Histosonics robots in action, with another 50 on the way.
The Mayo Clinic is a great example. They've just purchased their second system.
The robots aren't cheap. They're assembled locally and require hands-on training here, too. But the investment is soon likely to go far beyond just liver tumors.
So we've begun enrolling patients with primary pancreatic cancer and tumors. Early results are unbelievably encouraging. My dad passed away of pancreatic cancer. It's just a horrible disease.
I wanted to ask you about that. That would be a game changer.
Even if we can show that we are improving the quality of life, we put this patient in a better position than when they drove to the hospital. And we really believe in liver, kidney, pancreas, and well beyond. The answer is going to be yes. Now you've got a really robust bubble cloud.
That also helps explain why investors, including Jeff Bezos, gave these tiny bubbles a massive yes this week.
2-5 billion.
Exactly, a couple of billions.
Does that seem real?
No. In fact, the goal when I started was in the 200 million range. So we thought, if we could double that, that would be a really nice outcome. So $2.25 billion is significant, but honestly, we're just getting started.
And if you're wondering what that new majority stake means for this nondescript industrial park,
This doesn't look like a headquarters of a $2 billion.
It will. Come back in a couple of years. It will. First goal is industrial park domination.
But do you think the long-term future of this company is here in Minnesota?
Oh, of course. Yeah, the headquarters will forever be Minnesota.
I wanted to ask that question because Minnesota can't claim inspiration for this technology. It actually started at the other U of M, Michigan, back in a lab in 2001, but it has certainly come a long way, Jana.
So it started back in 2001, 24 years ago, and it's just working towards it. And the gentleman you talked to there has just been a part of it the whole time, or is he a new adopter?
He came on as a CEO a little later. I met one of the original developers today. It started in a garage in Ann Arbor after it left the university, and it's just been building from there.
Crazy stuff. Thanks, Ken.
Sorry, try to get this to stop.
Today on this crossover of
Okay, let's get back to the PowerPoint. Okay, so our first case was done November 5th of 2025. I do believe we've done 2 more cases since. Here we have a picture of the circulating nurse calibrating the machine, and there is a little preparation required for the patient. So it is ideal for the IV to be placed on the patient's right side. The area where the treatment bubble water bath is going to be placed should be shaved so that there's optimal contact with the patient. And then the patient actually needs to be pre-warmed in the pre-op area. The water bath that we've been mentioning is 30 liters of ice water. And because the pure volume and the way the equipment is put together, there is always a small potential for leaks of that cold ice water. The basin sits close to the patient, roughly 3 to 4 finger breaths between the basin itself and the patient. And then castor oil is used between the patient and the water bath. And then in the water bath, an ultrasound device is inserted, and that's how the treatment is given. The patient is usually positioned in the lateral or supine position. There is a half a beanbag under the patient, and then a plastic mesh, and then the patient goes on top of that. There is no arm board on the patient's left side because the doctor stands on the patient's right side and the histotripsy machine is on the patient's left side. And based upon how the machine is, there needs to be enough distance to able to get to the targeted area. No movement of the patient is required. It's an absolute must. So a double lumen tube is used to ventilate the patient and to prevent the lungs from moving the liver. And high dose of muscle relaxant is also utilized. We also place on upper and lower forced air warmers on the patient and have 2 machines in the room. Those 2 warmers actually need to be the old bear hugger blankets and not the bear hugger gown because we need to cover up as much body surface area. The first case, I actually watched the patient's body temperature drop 1 whole degree, although I was able to put on the lower body bear hugger immediately after she was anesthetized. So here we have the assessment and preparation. So the patient is brought into the room, and before they are anesthetized, the doctor looks with the ultrasound 1 more time and makes sure that there aren't any changes and that we can actually proceed with the procedure. And then the equipment, excuse me, can be attached to the bed once the patient is anesthetized and positioned appropriately. And then we put on the diaphragm and make sure it is connected and bring it up and over on top of the patient, and everybody verifies that it's in the correct position. Now, this was a training day morning of before the first case, and the rep is on the table. She is just holding her arms up to keep them out of the way to make it more simple for everybody. And then water is instilled. Again, this is ice water instilled into this bath basin. Once it is filled, towels are surrounding it, holding that diaphragm, helping to collect any water that might potentially leak. And that plastic mesh I mentioned earlier gets attached to that water basin. And then here we have the water basin filled with water, and the histotripsy machine is placed into it, and the ultrasound is here. And that's how the patient gets the treatment. And then this is the picture of the actual patient receiving treatment. There's an upper and lower body bear hugger on the machine that were actually started pretty quickly upon anesthetizing and positioning the patient. You see that mesh holding the diaphragm of the water basin and towels in place. And then you see the beanbag also assisting with positioning the patient. So, what does this mean post-operatively? So, it was decided that all patients will go to phase one recovery. The patients typically don't have any pain because, again, this is non-invasive. However, that does not mean that the patient didn't come in with pain of some sort. So, we do want them to be satisfied with their care, and we need to make sure that all their pain is under control as much as possible. And then we need to make sure the patient maintains their body temperature. So, if for some reason during the 90 minutes of the procedure between preparation and the actual treatment, we are unable to maintain the patient's body temperature, our recovery room can help us out by warming the patient during the phase one recovery time. And then the patients can go to phase two and be discharged home. And that is the ultimate goal after the procedure is that all patients go home. Finally, I have a list of references. Dr. Peter Coleman, Angelica Delaney, and myself were involved in the first case here at Abbott Northwestern Hospital. Dr. Peter Coleman is our go-to person on the anesthesia realm of things. And then underneath are other resources, references that I utilize for the presentation. Please let me know if you have any questions. I will be happy to answer them. And if I don't know the answer, I will look it up and get back to you as quickly as I can. Alrighty, thank you and have a great day.